Second speaker today in the Young Physicians Forum is Dr. Devasmita Vijayasundara, Senior Registrar in Neurology from the Institute of Neurology, National Hospital of Sri Lanka. He'll be talking to us about diagnosis and management of Subarachnoid Headache, the Neurologist report. Over to you, Dr. Vijayasundara.
Thank you, sir. Thank you for the kind introduction, and thank you to the CCP for this opportunity to present. So my topic for today is on the diagnosis and management of subarachnoid hemorrhage, the neurologist role. So I selected this topic because when it comes to hemorrhage of any sort in the brain, the first person that may come to mind would be a surgeon or a neurosurgeon. So I believe that we as neurologists and of course as physicians have a larger role to play. So it's my task today to convince you of that. So I will do so using this outline. So throughout this talk, I will be talking about non-traumatic spontaneous subarachnoid hemorrhage. And this is a cause of hemorrhagic stroke. And although it is the least common cause of stroke, it is important because it carries a very high case fatality rate. And even in those who survive SAH, there is a significant long-term disability as well. Fortunately, the incidence is only around 6.1 per 100,000 person years. It peaks in the 5th to 6th decades. It's higher in females and in certain ethnic groups. So the rupture and intracerebral aneurysm is the commonest cause for SAH, and it accounts for around 85% of cases. But it can also be due to bleeding from other vascular malformations. And this is in fact more common in children, whereas in adults, aneurysmal rupture is more common. And in a minority of cases, we may not be able to find a source of bleeding. So I'll be talking on that in later slides. These are primary types of SAH. So it can also be secondary to other pathologies as well, such as commonly trauma and also other brain pathologies such as reversible cerebral vasoconstriction or amyloid angiopathy, even venous thrombosis, and even certain systemic conditions like coagulopathy, infections, and certain drugs. So moving on to the radiology, I'm sure everyone in this audience is familiar with this image where you have the characteristic star-like appearance in a non-contrast CT where you find blood within the basal cisterns extending into the fissures. So although this is the characteristic appearance of an SAH, it is not the only way that SAH can manifest radiologically. So if I take your attention to this CT, you can see that the blood is restricted to the perimesencephalic region and the prepontine cisterns and not really in the fissures. So this type we call perimesencephalic subarachnoid hemorrhage. So there is another type which is even more focal. I hope you can see this. So there is a small amount of blood within the sulci, and this is called Convexity SAH. So radiologically, there is a grading system. What is used is the modified Fisher scale. So I won't be going into detail on this, but just to say that as there is a severity grading, and as the grading severity increases from a thin layer of blood to for diffuse SAH with a thick layer with intraventricular extension, the risk of vasospasm increases. So that is what is given in red. So as the severity increases, there is a higher risk of vasospasm. So I'll be talking about that later. This is an interesting radiological entity, a pseudo SAH. So when this appearance is seen, the radiologist will report this as an SAH. But we as clinicians will go back to the history, and if there is nothing in the history to suggest an SAH, it would be a pseudo SAH. So this can commonly occur in patients who have hypoxic brain injury. And even in an MRI, there can be artifactual causes that can lead to an SAH appearance. So how do you make a diagnosis of SAH? So as always, it is through the history, examination, and investigations. So these are the clinical features. So in the history, 70% of the time, the patients will present with a headache, most often described as a thunderclap headache, And in about 40% of cases, there may be a sentinel headache as well, preceding the actual SAH. And also, patients can have nausea, vomiting. They can present with seizures or even as a stroke. And the patients will have abnormal mental status, and there can be signs of meningism because of the blood irritating, and also focal neurological deficits such as third nerve palsies demonstrated in this figure, and even there can be false localizing signs like a false localizing 6 or hemiparesis, hemiplegia. And additionally, patients may present in cardiac arrest. So even systemic complications may be presenting symptoms of an SH. But most of the time, 50% of the time, patients will not have any significant neurological deficits other than the headache. So there is a clinical grading system as well. So it can range from having a mild headache and accumulation of various neurological deficits up to foam. So as I mentioned before, the characteristic clinical feature is a thunderclap headache. So this term was first coined in 1986 in a case report. And so what is described as the worst headache in their lives. So what I'd like to draw your attention to is it is not only the severity, but the fact that the pain in the headache reaches its maximum intensity in less than 1 minute. So that is an important feature of a thunderclap headache. So although the first differential diagnosis and perhaps the most important one that you should think of when a patient comes with thunderclap headache is of course SAH, but it's certainly not the only cause. There are other secondary causes like pituitary apoplexy, venous thrombosis. And interestingly, it can even be caused by a primary headache disorder. So I'm sure the medical registrars in the audience will agree with me when I say that headache is a very common presentation to a medical ward or to a medical clinic. So not all patients who come with headache need extensive evaluation for an SAH. So how do we pick out those patients that need urgent evaluation? So this is the answer, the Ottawa SAH rule. So this is a simple screening tool with 100% sensitivity. So we will not miss any patients to further evaluate for an SAH. So of course, this is applied in adult patients with sudden onset severe headache who do not have any neurology. So obviously, if the patient has focal neurological deficits, you would investigate. But if not, you can apply these 6 clinical features. So I will take you through some patients we have come across and see how useful this is. So this is a 35-year-old lady who is a known patient with migraine, and she was referred to our headache clinic with a sudden onset severe headache. And there was a brief period of loss of consciousness right at the onset of headache. And even while we saw her at clinic, she continued to have headache and photophobia. And there was some neck pain as well. So I'm sorry, there's something wrong with the slide. So when you apply the Ottawa SAH rule, there are 4 out of the 6 clinical features. You have patient with the thunderclap headache, neck pain, limited neck flexion, and witness loss of consciousness. So obviously this patient needs imaging. This is her CT. Do you see the SAH? I hope you do. It's actually very subtle. So there's interhemispheric blood. So if you had not taken a proper history in this patient, you might have even missed this. So this patient ultimately was found to have a ruptured anterior communicating artery aneurysm. So our second patient is a 51-year-old female who was transferred with a sudden severe headache, and the neurological examination was normal, but she was found to have very high blood pressure, and also she gave a very interesting family history of several members having kidney disease, and she also had bilateral ballotable kidneys. So when you apply the SAH rule, she has 2, but more than that, there's something else in the history, and I'm sure you would agree with me when I say this patient has autosomal dominant polycystic kidney disease. And if you go through the literature, you will find that 10% of patients with PCKD have intracerebral aneurysm. So obviously this patient should be evaluated. This is a CT. I've provided several cuts. So do you see the SH here? The answer is no, because this is a normal CT brain. So then I will use this opportunity to talk about imaging in SH. So as we have done, the first modality is the non-contrast CT, which is easy to access and it will provide rapid results. But the caveat here is that the sensitivity will decrease with time. So the CT may fail to pick up blood as times go on. So we can use MRI, special MRI sequences to pick out subacute or chronic blood. And also all patients with SH should undergo vessel imaging. With the first line would be a CT angiogram, and it has very high sensitivity, but small aneurysms can be missed. So digital subtraction angiography or a DSA is the gold standard, and it is not only diagnostic, but it has a therapeutic value as well. So coming back to our patient, this is a case of a negative imaging with a high clinical suspicion of SH. So this is the place for a lumbar puncture. So what we look for in the lumbar puncture is the presence of xanthochromia by spectrophotometry. So that is important to ask for because if examined visually, we have a potential of getting a false report. So this is a normal CSF compared to a xanthochromic CSF by visual inspection. But what is ideal is to perform a spectrophotometry where what is analyzed is the blood breakdown products of bilirubin, which has a light absorption at a specific range, which can be quantified. So that is the ideal way of looking for xanthochromia. And because bilirubin is light sensitive, the samples should be protected from light and transported immediately. So before I go into the management, I'd like to talk briefly about complications so that you will know what you need to manage here. So brain injury following an SH has two phases. So in the early phase, that is within the first 72 hours, with the rupture of the intracranial aneurysm, there is sudden transient increase in intracranial pressure and transient global ischemia. And with this, there's a triggering of a cascade of events that lead to cell injury and cell death. So it is not only within the brain, but there are several important systemic complications as well. So with the SH rupture, there is a sudden catecholamine surge, and that can cause neurocardiogenic injury. So that can cause a myocardial stunning, something like a Takotsubo cardiomyopathy. And in addition, there can be ECG changes such as QT prolongation, deep inverted T waves, which are known as cerebral T waves, and also there can be troponin elevations as well. And not only that, there can be neurogenic pulmonary injury, AKI, and metabolic disturbances such as hyponatremia and even DIs. So these are the life-threatening hyperacute complications. And as you can see, there's a hydrocephalus developing. So this may occur in 20% of cases. And of course, this is where the neurosurgeon should come in. So this needs emergency CSF diversion by inserting an external ventricular drain or an EV. Other complications can be aneurysm rebleeding and also elevated intracranial pressure and also hemodynamic and respiratory insufficiency. Going into the delayed phase, so this is the period between 3 days to 3 weeks. So the main pathological mechanism is the angiographic vasospasm. So this is said to occur in about 70% of patients. So what happens is because of the release of hemoglobin and other factors, there is nerve injury which causes depolarization leading to vasospasm. Not only vasospasm, there can be formation of microthrombi, microemboli, and this together leads to waves of cortical spreading ischemia, which can lead to new neurological deficits even after the aneurysm is secured. This is an area for research for various therapeutics. So even though several agents have been trialed since the 1980s, the first agent to have been trialed, which is nimodipine, introduced in 1983, is still the only agent that has been proven to have a mortality benefit. So this is a calcium channel blocker, which is given orally. So in 2020, intrathecal administration of imodipine has also been tried, but unfortunately that was stopped early because it was futile. So keeping that in mind, let's go into the management. So there are guidelines for this. This is the HASA guidelines. So these are the class 1 recommendations: oral nimodipine for 21 days and securing the aneurysm as early as feasible. So the options are surgical clipping or endovascular therapy. So over surgical clipping, endovascular therapy is now preferred in our cases if possible. So the methods they use would be insertion of flow diverters or aneurysm coiling with or without stenting. And additionally, euvolemia should be maintained to maintain cerebral perfusion pressure and blood pressure control. So the target is said to be systolic less than 160. Supportive management is also important to maintain normothermia and to avoid hypoglycemia. So in blue, I have given the targets mentioned in the Neurocritical Care Society guidelines, and also early identification and targeted treatment of DVT and treatment of anemia to a target around 8 to 10 grams per deciliter. And also hyponatremia is a common complication. This may be due to cerebral salt wasting or SIH. So this should be managed with hypertonic saline or fludrocortisone. And what they say is to avoid fluid restriction, because here we need to maintain euvolemia. Headache, although it's very common, is difficult to manage in SAH. So the first line is, of course, acetaminophen, and opioids can be used as second line. But NSAIDs should be avoided because of the bleeding risk. But once the aneurysm is secured, they can be used. And several other agents have also been tried, but there is limited evidence for these. Some areas of controversy whether tranexamic acid is indicated. So there is very little evidence for this. So when you compare the guidelines, the HA guidelines say that if there is unavoidable delay in securing the aneurysm without significant risk of rebleeding without medical contraindications, you may consider antifibrinolytics for a short period that is less than 72 hours. And the Neurocritical Care Society guidelines go on to say that if it is more than 48 hours following aneurysm rupture, it should be avoided because it carries more risk. Similarly, routine use of anticonvulsants is not recommended. And what is hypothesized is that in the initial period, a seizure can cause a rapid surge, a rise in blood pressure, and that may lead to rebleeding. So you may consider using prophylactic anticonvulsants, but there's low level evidence for that. And if at all it is used, it should be a short period, 3 to 7 days. So let me conclude by taking you through some of the dilemmas that we face in everyday practice. So this is a 53-year-old lady who presented with 3 episodes of thunderclap headache over a period of 5 days, and her examination was normal. So when you apply the rule, sorry, this is not coming. So with her age and the thunderclap headache, she has 2 out of 6 from the screening tool. So obviously she needs evaluation. This is her imaging. I hope you can see. So in the arrow points to blood within the salsa in the temporal occipital region. And this is an MRI flare sequence which confirms that. And there is blooming in the SWI. So this is a convexity SH. This is her vascular imaging. So you can see she has a normal MR angiography, MR venogram, CT angiogram, as well as the DSA are all normal in this patient. So when it comes to convexity SH, it's actually commonly due to secondary causes such as posterior reversible encephalopathy syndrome, amyloid angiopathy, or reversible cerebral vasoconstriction, or venous sinus thrombosis. Although these may be the causes of convexity SH, we were unable to find any evidence of these radiologically in our patient. So this is an angionegative SH. So broadly, angionegative subarachnoid hemorrhage is divided into perimesencephalic and non-perimesencephalic SH. So as I described earlier, this perimesencephalic SH is a benign variant and considered to have excellent prognosis. And unlike in the classic aneurysmal rupture, it affects men more than women. But the caveat here is that 10% of the time, even patients who present with this presentation may have rupture posterior circulation aneurysms. So you still have to evaluate as for a aneurysmal SAH even with this appearance. The other type is, of course, when you have a classic SAH on the CT, but the DSA or the angiography is negative. So what we usually do is to repeat the DSA, and in 7 to 14% of the time, you may find the aneurysm. So the initial DSA may have been negative because of vasospasm. However, in a significant proportion, still the repeat DSA may also be negative. So this is a questionable area, and actually the cause or the source of bleeding has still not been found. So it is theorized that it could be due to a self-repair of a microaneurysm, vasospasm, or another source of bleeding like a venous source. But anyway, overall, these patients who have non-aneurysmal SH are said to have a better outcome than those with aneurysmal SH, and even more so in patients who have perimesencephalic SH. So let us look at the other end of the spectrum, that is unruptured intracerebral aneurysms. So if I just assume that there are 100 people in this audience, 3 of you will have intracerebral aneurysms, which are obviously unruptured. But less than 1% of these will rupture per year. So compare that to the 6% risk of complications following aneurysm treatment, which can include death and even death and permanent disability. So you must predict which are the ones that can give rise to a potential SAH. So there are certain risk factors that we can look at to predict whether this needs to be intervened upon or not. So these can be both non-modifiable and modifiable risk factors. So the non-modifiable risk factors are included in various scoring systems that you can use to determine whether it should be intervened or not. What we should focus on are the modifiable risk factors: hypertension, smoking, heavy alcohol use, and sympathomimetic drug use. So we can intervene here and prevent a potential SAH. So briefly, this is the outline of management of unruptured intracranial aneurysms. So basically, in a patient who is older than 60 years with a larger aneurysm, specifically in the posterior circulation, you would consider intervening. And there are other factors such as presence of hypertension, a family history of SH, or certain conditions like PCKD that will also push you towards actually intervening. So I will conclude by saying that subarachnoid hemorrhage is a neurological emergency with significant morbidity and mortality, and the Ottawa SAH rule is a reliable screening tool. Guideline-driven management improves outcomes, and the management of angionegative subarachnoid hemorrhage and unruptured intracerebral aneurysms is complex and needs expert opinion. So these are my references. Thank you very much for your kind listening. And also, I'd like to take this opportunity to thank my primary trainer, Dr. Dinsar Sennaika. Thank you, sir, for your guidance and support. And also all my pre-MD trainers at Profinite Medicine NHSL, and also the Ceylon College of Physicians.
Before the mechanism of rupture, there is leakage of the blood, and we call it sentinel headaches.
Yes.
And that's progressive headaches for covering over a period of time. In that situation, if you advocate taking the environment, you suspect, even there's no evidence of a clearness hemorrhage, you advocate taking an environment on that there are patients.
So this is a patient, thank you for the question, sir. So this is a patient who comes with sentinel headaches, who does not have evidence of thunderclap headache. So whether or not we will do imaging in this patient. So again, here we can apply the Ottawa SAH rule and see whether we would, obviously the first line would be a CT brain. And if we are still suspecting a potential rupture, it will not be picked up by an MRI scan. So I think we can, if we are suspecting such a patient would have a potential SAH, we can admit the patient and we can just even monitor the patient because it will not be picked up if we do an MRI scan of the brain.
Sometimes you get patients who come with classic Thunderclap Headache, but so you get CT negative. And but sometimes you repeat the CT, you might get a positive response. So how long do you think you should wait before you repeat the CT?
Actually, if there is a thunderclap headache and you do the CT, it is the most sensitive within the first 6 hours. So if the initial CT is negative, there is no place to repeat the CT. If at all, the second line, the traditional approach would be to do a lumbar puncture for xanthochromia. And the other option would be to do a CT angiogram. So not a non-contrast CT, but a CT angiogram, because certain patients may not consent to a lumbar puncture, and of course it carries some risks, whereas a CT angiogram would be non-invasive, and when you consider the radiation also, it is not it's not very significant. So there have not been trials comparing whether the second line investigation should be lumbar puncture or CT angiography, because that actually needs more than 3,000 patients. So there have actually been studies determining whether a lumbar puncture is indicated, whether the second line should be a CT angiogram. So they have found that a CT angiogram as a second step would in fact be around 98% sensitive in detecting an aneurysm, so thereby avoiding a lumbar puncture. But of course, there are drawbacks of that also, because there is as I mentioned, the incidence of unruptured aneurysms is 3%. So a patient does not have an SAH appearance on the CT, but you pick up an aneurysm on a CT angiogram. So still that patient might need an LP to confirm that this aneurysm has actually ruptured. So I think best is to give the option to the patient, but traditionally what we do after a negative CT would be a lumbar puncture.
Thank you.
Any more questions? Yeah, in absence of any more questions, thank you very much, Dr. Sundar, for that presentation. There is a certificate of appreciation, please accept it in our college.